So welcome everyone, and thank you for joining us for the Penn State College of Medicine COVID-19 ECHO series for skilled nursing facilities. We're delighted to have you join us for today's session. My name is Jackie Sable. I'm a member of the ECHO team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box for our record-keeping purposes. Please stay muted unless you are speaking. You can use *6 if you're dialing in, or the microphone icon on the bottom left side of your Zoom window for muting and unmuting. You can also use the chat for communicating with us. We realize that question and answer time is important to you, and we try to categorize and address as many questions in the session as possible, but we do follow up with any unanswered questions afterwards in an email. If you have suggestions for future COVID ECHO topics, either for the Skilled Nursing Facilities series or our general COVID-19 series, please share via the chat tool or email us at echo@psu.edu. Please remember that no personally identifiable information or PHI is allowed when we discuss cases. We are recording these sessions, and we share all materials and recordings after the session. In the spirit of all teach and all learn, the basis of our ECHO model, we will be on a first name basis during the session. For those of you who are not familiar with Project ECHO, our ECHO sessions will always begin with a brief lecture and are followed by either a case discussion or questions and answers. Today's session will include a lecture and potentially a case discussion on optimizing medication management during the COVID-19 pandemic. And that will be by Doctors Nicole Brandt and Daniel Hemowitz. And Dr. Amy Westcott is also on and participating as part of our panel. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State Online, as well as our team of presenters, and they do help to field questions. But please remember that this is all teach, all learn, so everyone can share both questions and answers. And with that, I am going to turn things over to Nicole and Daniel to get things started.
So Dan, do you want to start?
Dan, you're on mute, I think.
Yeah, I can't hear him.
Oops, you're right. I said, firstly, I'm very informal, so you can call me Dan, Jackie. No, Nikki, you're on. Go to it.
Okay, sounds good. Well, as Dan noted, we're going to be pretty informal here and encourage you to ask questions as we go through. The intent and overview is really to give a background and goal of a guide that we put together with a partnership at the University of Maryland and the USD Prescribing Research Network. We're going to give an overview on some of those recommendations that came out of this guide, some key issues to consider when implementing recommendations, and importantly, to talk about ways that we can avoid unintended consequences, and some of the other resources will be mentioned later. Next slide. So just to give a little bit of perspective, I know in the slides that will be shared with you, we have some disclosures. So as mentioned, I'm at the University of Maryland, have worked with many on this team through the years, and have worked as a consultant pharmacist in the post-acute long-term care setting. And we know in post-acute long-term care, and especially if you're reading the media nowadays, there's a lot of attention given towards some of the concerns of the care delivery and resources. And we've known historically for a long time that residents in long-term care are often prescribed many, many medications given many times per day, which has left a huge burden on our nursing staff. Oftentimes these medications may be unnecessary and potentially harmful. And so we've convened a group during the beginning stages of the pandemic to really look at medication management and optimizing medication management so we can ultimately reduce burden on the direct care staff and potentially reduce infection transmission. So we try to tackle some of the topic discussions such as nebulizer treatments or other things So we put this guide together, quite honestly, and as Dan knows, because he reviewed it in a little bit over a week. It was about 10 days, and it really took a team effort. But this is the background of why we did what we did, is to give resources to communities freely throughout the United States and beyond. So next slide. So really, again, the intent of this guide, which is available on our website, and some of you may have seen it and would love to hear if you chat in on how you might be using it. But the important aspect of this guide was to improve resident-centered care. So we actually employed past surveyors on our state and national leaders who know the regulations surrounding post-acute long-term care to give us guidance. And one of the key things and discussions that came up, and all of us who practice in long-term care know that this needs to be resident-centered, and really, again, making sure that we're being mindful of looking at each resident's needs, but also being mindful that we need to streamline medication administration when we've got a shortage of staff. But the intent of this guide is to complement and not replace other efforts to improve care quality. And again, the intent of this guide was to be used during COVID-19, but I believe the principles that we've put together are really principles that can be used independent of pandemics, and have really bore out of existing work that many have done, such as Dan and Amy and others, in terms of really providing good clinical care for vulnerable populations. Next slide. So again, have to give the legal disclaimer here. It's advisory. And really, when we talk to facility leaders, medical directors, we realize that some areas are being impacted more than other areas. So the aggressiveness of change may vary depending on your staff, depending on your circumstances. But ultimately, like any tool or resource, it does not substitute for clinical judgment. So next slide. So when we went through and put this tool or resource together, and really the area that's gotten most attention has been the recommendation section of the website, but we took and broke down into certain considerations, and the first considerations are really medication specific. And again, this is a tool to optimize medication management during COVID-19. And so the first thing we wanted to look at is, could we potentially deprescribe or hold medications that might not be needed at this time, again, to reduce medication burden, medication passes. So we felt that there are many medications that could be safely discontinued that don't put our older adults or our residents at risk for adverse drug withdrawal events. And so we paid particular attention to dietary supplements and other issues. We also took into consideration medication monitoring aspects. And really, I know there's a lot of discussion about how often we should be checking finger sticks and doing other type of monitoring, such as blood pressure. But if someone who's stable may not need to have those touches as often, which again could increase transmission and burden on our direct care staff. Next slide. The other thing that we wanted to be considered, and we learned from talking with formulary management companies and plans and other advocates, that maybe some of the formulary issues of the past may not be as much of an issue during COVID times. And so looking at some of our formulations, and if we're not crushing those medications, switching short-acting to long-acting formulations. Again, looking at insulin and seeing if we can simplify the regimen so we're not giving as many doses of insulin injections. And then we looked at the utilization of analgesics and to see, and one of the things we had a lot of discussion on was acetaminophen in terms of being used regularly or as needed, especially for fever surveillance. So these are just some medication dosing considerations. Next slide. And then medication timing considerations. And what was interesting is we were working with a long-term care pharmacy who was able to generate reports on outlier medication dosing administrations. And it was really interesting. It almost looked like a blood levels over time, and seeing peaks of when there's lots of medication passes or less medication passes. But in one facility, there was upwards of 14 different medication passes based on the timing of different meds within their building. So could we consider consolidate the medication administration times, eliminate outlier medication administration times, and allow some liberalizing the times. So we really try to focus on that as well to, again, reduce burden on those direct care staff. Next slide. So we know that with this virus, we have to be mindful of transmission. So we had a lot of discussion about reflux cough, and some of these pills that we give can be very difficult to swallow. So we talked at length about, could we look at other formulations to make it easier for our patients, our residents, to swallow. So this was another medication administration consideration. Next slide. And then where we got into a lot of discussion, because this is relevant to COVID-19, was discussion on the utilization of nebulizers. And we know that the data is limited oftentimes in the population we serve due to cognitive impairment or physical limitations about the ability to manage handheld inhalers. So we put a stipulation here that using them if possible, but being mindful of some of the limitations with the use of handheld inhalers. So the key thing as we think about implementation, we need to look at each and every recommendation. We need to work as an interprofessional team. And I think for me as a co-lead on this guide with Mike Steinman, another physician leader, that we need to engage our nursing team, our direct care staff, our families, our residents, and our leadership, because this takes a full team, a full village to make changes focusing on medication management. We need to do it in a stepwise, resident-centered approach, not a blanket approach that impacts everybody the same, because we know that every one of our residents are quite different. But some of the considerations when we look at this is we need to look that we're making changes that are essential for infection control, whether that's transmission or other risk factors, looking at changes that might be low risk and quickly done, that are not going to put our residents in harm's way. But there are some changes that are low risk but may take more time for person-centered evaluation, communication, implementation, and monitoring. So some of the discussion came up regarding psychoactives or antipsychotics and gradual dose reductions, but we know that there's a lot of uncertainty with those medications, and we need to be mindful as we reduce them and over a period of time. So that might be a higher risk medication consideration. Next slide. So what we also looked at in terms of implementation, and look forward to the other presenters talking about implementation tactics, some medications can be temporarily discontinued, and we talked about things like bisphosphonates, but they need to maybe be reestablished for potential future resumption. And then again, looking at potential harms in light of poor communication. So we need to make sure we have great communication amongst providers, residents, families, and care partners. So on our tool guide, we actually provided sample letters that could be given to family members, to residents, and others, so they know what medications might be being addressed or discontinued. Next slide. And so when we look at any tool, I think it's mindful. I've had the privilege of working on the Beers criteria for the last 3 segments, 2012, 2015, and now 2019. And I know with any guide or any tool, there's always the potential for unintended consequences or harms. So purposefully, we try to identify that and put some tactics in which to reduce those unintended harms. So again, within the guide, we put together a table that you could reference, but for instance, failure to restart useful medications that were temporarily discontinued. And hopefully through the consultant pharmacists, through the nursing, through the prescribers, that we establish a list of those medications that are being temporarily stopped. But also being mindful that some symptoms may reemerge. And we know sometimes holding of allergy medications during this trying time, those might be problematic for our residents. And we also need to be cognizant during this very sensitive COVID pandemic time that we don't want residents and or families feeling like we're abandoning them. But really we're trying to put them at the center of their care, and through good communication and good intentions, we can help improve the delivery of their medication-related needs and monitoring. Next slide. There's more, of course. So we continued on in terms of, we talked a little bit about the increased cost, but again, there's been attention given to formulary aspect and cost issues. And I'm very cognizant. I spent a couple years at the Centers for Medicare and Medicaid Services about legal or survey consequences. So that's why we grounded all of our recommendations in the resident-centered approach, and documenting the rationale of why we're doing it, and monitoring. So I really feel that those principles will help to strengthen if a surveyor were ever to question these changes in the future. Would love to hear others' thoughts about that too. Next slide. And at that, I'm going to turn it over to Dan. Thank you.
Thanks, Nikki. So if I wanted to be succinct here, depending on time, I would just say I agree. And then we could go right to questions, but I guess I should do my piece. You know, when I was thinking about all this, I was, for some reason, stuck in my head was Love Time of Cholera, but that title was taken. So I don't know if medication deprescribing in the time of COVID-19 is a little catchier. You know, I will say that one of the reasons I agreed with the stuff when Nikki sent this to me was that I was doing exactly the same thing at the same time. So you know, you agree with people who are doing the same thing you do. So that's how I felt. So I could say that, you know, the book's already been written. See, right, Nikki, that's for you. But don't judge a book by its cover.
That's kind of scary.
All right, I have one more book joke, but we'll do that later. Okay, next. Part of the issue here, I think, is going to be the semantics. I think most people on the line, I think we're probably already the choir. The issue is how do you get people who don't do this into doing it? And many people are not familiar with the term deprescribing. There was one, I think, Canadian study that said 7% of people knew it. My problem with this is that I don't enunciate very well. And somebody, I was telling them I was going to talk on deprescribing, and they said how they were very fascinated with e-prescribing. So I said, no, I don't know anything about e-prescribing. Deprescribing, I know. I like the term emergency deprescribing personally, because that's sort of what this is. And that's one of the things that I'll talk about, which is that I'm not sure people who aren't in this yet realize that a pandemic is a crisis, a real true crisis, and it's an emergency. But that term doesn't go over. Medication reduction works, but to me, if you're going to try to sell this, particularly to families, I think you might look at the concept that this is just a pause or a hold, right? So I'll be talking a lot about how you do it practically. It's certainly important in nursing homes, but I think it might be even more important in personal care and assisted living, because there you have less staff and hundreds of meds per staff. No, that's fine. Go ahead. You just move the slides as you want, Ellie, and I'll catch up. So what are some of the considerations of this? Well, Nikki touched on the financial part of this, and I think the easier step is to get a list of medicines that you can, basically most people agree you can stop. But the harder, the more sophisticated part of this is saying, can you do things that we don't normally do, which is I do not like combination medicines, but this might be a time for this. You know, adjusting insulins to longer acting, you know, it's much better in this time, but might be more expensive if you're going to use a, you know, short acting insulin with meals and then a basal one at nighttime. Same thing with the other thing. So there are financial considerations, and you should work with your pharmacist for that. Typically, I like short acting. I think most geriatricians like shorter acting medicines. But I'll say in a conversation I had yesterday, I was looking at, is there a relatively safe long acting medication used in its place? For example, if you're using Ativan 3-4 times a day, perhaps you could use clonazepam or Klonopin once a day. So it's a consideration. If you want to be a little more, again, sophisticated about it, many physicians who are not the nursing home doctors don't understand or don't agree with the concepts of primary prevention, which is that, stopping baby aspirin if they don't have heart disease, stopping a statin if they don't have, a disease associated with high cholesterol. So just high cholesterol alone, treating somebody for high cholesterol just in the presence of high cholesterol is primary prevention. And I think you can make a very good case that the literature supports that you don't use that over patients 75 or 80 years old. If you have somebody whose blood pressure is already low, or, same thing, the sugar, the cholesterol, you're actually checking hemoglobin A1Cs to see if you can cut down on diabetic medicines. That's the new paradigm. We talk about residents on or appropriate for hospice, and Nikki, that's brought up in the guide, right? But what I've found practically is when you really look and you say, okay, you have a residence on hospice, have medications been stopped that really are consistent with their goals of care, now they're on hospice, and you find they're still on statins, dementia drugs, many medicines that should reasonably have been stopped regardless of the COVID pandemic. Patients have symptoms, I like to taper proton pump inhibitors and make H2 blockers PRN. So that's a good example. You can taper or stop those, but you have to watch, because if somebody starts having symptoms again, you resume. If somebody is on iron and has a normal CBC, well, it's not going to hurt them if you stop the iron, or you stop the B12 even, because people are not going to suddenly become B12 deficient if they have a B12 level that's like 1200. They're not going to become B12 deficient in 2 months. They're just not. And of course, why is somebody on a medicine they shouldn't be on to begin with? Now, I have this thing about gabapentinoids. The only indication for gabapentinoids, FDA approved, is painful diabetic neuropathy. So if somebody's on that for another reason, you should look at that. I do have a reference for that. But sometimes people just get put on gabapentin or pregabalin just from somebody else, and you don't know why. So a lot of times you'll stop a medicine and somebody will be okay. I will point out, if you really, really need it, now pregabalin Lyrica is, you could use once a day, use shorter than you do gabapentin, but the medicines are not the same. They're not exactly the same. If you want comments, we can comment on that later. And something that I always love is doctors who've ignored consultant pharmacist recommendations in the past. Nikki, I hate to tell you this, but this happens. So this might be an opportunity where the pharmacists can readdress and say, maybe we can try it this time. Next. And the devil really is in the details here. That's the thing. You want buy-in from administration. You almost always will get that. The issue might be, though, perhaps if the company has some kind of relationship or owns the pharmacy. So just keep that in mind. Here's the key point. Don't wait for the outbreak. That is really important. I can't tell you how important that is, because what will happen is, if it would be great if you guys haven't gone through this, but I've gone through this in multiple facilities. And what happens is, if you go to a facility and you say, hey, let's talk about medication management now, where they are running around like chickens with their head cut off, their hair's turning gray before your eyes, and you say, hey, we'd like to potentially burden the staff with stopping medicines, they're going to say, we don't have time for that. So if you haven't gotten the outbreak yet, now is the time. I'm not saying this because Nikki's online. Well, maybe I am. How key the consultant pharmacist is. They're crucial here. Stopping the non-essential medicines is easy, but the more sophisticated stuff, you really, your consultant pharmacist is going to be your best friend, as are the providers. And what I find most of the time is that your NPPA are really making the rounds. They can look through the medication list. They can talk to the family. They're so, so important to this. You have to get a letter. I suggest reaching out to the prescribers first. It depends on your setting. If you have a setting like your big organization and you can just lay down law and say, this is what we're doing, that's fine. But if you have a lot of prescribers, it's good to reach out to them. And I think family communication is important. I'll note about the guide is when I called Nikki about it, they said, we have this letter, we've written this letter. So I don't know, those of you who know me won't be surprised. I say, well, thank you for those letters, Nikki, but I think I can write them better. And she says, no, Dan, you don't understand. Alice Bonner wrote these letters. They're all like correct me if I'm wrong about this, Nikki, they're all scientifically validated, and you, sir, are no Alice Bonner. That's what you said,
say that,
right?
Dan.
That's sort of what you said. But I guess the point is that, you know, you can take a lot of principles. You're allowed to write your own letter, though, right? I could if I wanted to. I hope that's right, Nikki, because I did anyway. And I'm happy to share, just so you know, and you compare. And if my letter looks better, you can tell me. And if you don't think so, please don't. You want to in-service to your staff. This should not be hard, but, you know, you can develop communication bullet points with your staff about what the message is. I've done that with my staff. If you want me to share it to you, I'm happy to. Next, please. So the barriers are, of course, waiting too long. You want to be proactive about this. Sometimes the prescribers, there will be issues. Some prescribers they're more comfortable with the alternative medicines, the herbal medicines, but they're not quite as comfy with prescription medicines. Some of them say, well, you know, we've done this already. One very interesting response I got was there was one doctor who I said, well, you know, you want to try to do this so you decrease nursing med passes. And a doctor said, well, you know, we do that already. Really? You write medicines because you're concerned about the number of med passes that the nurses are making? Amy, have you ever heard, Nikki, have you ever heard such a thing? None of the doctors I know do that sort of thing. So maybe they do, but I don't think so. One of the doctors was said, well, Dan, they say, you know, you don't have any data. We need data. So I did ask Nikki about, right? I sent you an email about that. And there really isn't data. It might be interesting. I'll show you something I got on that later. But, you know, the doctors don't know the prescribing principles. What Nikki said is right. The families feel like there's loss of control. Again, it depends how it's worded, and it depends on your facility. For example, I go to one facility where the nursing center has electronic med pass and things, and the personal care has paper. And there's an entirely different system of tracking and stopping medicines. We talked about money. The whole issue is you want to make sure you don't increase work for the staff and you don't increase med errors because meds are on, quote, hold, unquote, right? So that's what you want to look at. I still think, though, if they're complaining of work, what I've gotten so far is there's been a ton of buy-in from the DONs, and the staff is really appreciative. So the amount of time you put into this is going to be paid back over in spades by the amount of time you're going to be saving your nursing staff from giving out medicines and the potential of good outcomes for the residents. Nikki talked about planning with the end in mind. You got to figure out, you have to have your team that meets. You know, we're saying, so how, you should meet regularly, I think, to look at what are your next steps, how are you going to do this? But I think that holding med, some places I've seen have held med for 30 days. I personally think that's a little too short. Maybe 30 days is when you reevaluate because you might not see any difference after 30 days. I think 60 days, I think that's what you said, Nikki, right? The 8 months, 8 weeks, I think that's more reasonable. Part of the issue, though, a big issue with deep prescribing, with medication management, is always comfort with risk. Now, I happen to be very comfortable with stopping medications. I think it helps people. It's anecdotal in my experience. You know, the danger is you don't want to be a medication nihilist about this, but, you know, you will. I feel it's no risk, no reward. So you won't know if somebody can tolerate not being on a medicine or has less side effects on the medicines if you never try stopping it in the first place. So next, please. We talked about prescription medicines. Docusate is interesting. You know, I talked to one of the doctors and they're like, no, we're not going to stop Docusate because the residents are already stuck in their room. They're not getting therapy. They're not getting out. They're going to get constipated. So I said, well, a couple things here. The first is Docusate doesn't really work for constipation. Ladies on the line, please forgive my language here. It turns your poopy to mush. Forgive me for saying that, but that's true. It only changes stool consistency. And I say, look at your bowel protocol. The nursing homes are going to use a bowel protocol anyway, and Docusate is not on anybody's bowel protocol. If it worked with constipation, it would be, right? The other thing that you can use here is you can use deep prescribing precepts, concepts against them here. You say, hey, look, you know, part of the point of stopping medicines is that they have unrecognized adverse events, right? So I think there's a really good chance that were you to stop some of these non-essential medicines like calcium, for example, or changing their iron from TID or BID to daily or once a day, you might not need anything for constipation in the first place. And they say, So statins, the message, they'll resist this. Again, I don't think not treating somebody's cholesterol for 2 months is going to make a difference. I think a lot of people get put on magnesium because they get put on it in the hospital. And the reason that people get put on magnesium in the hospital is because they can. So because, they check a level, it's low, they put it on it. I would be comfortable stopping magnesium, certainly if somebody does not have heart disease or particularly a history of arrhythmias. The bisphosphonates is the same thing with statins with treating osteoporosis. Now, I mentioned the overactive bladder medicines because this is an instance where it's the opposite of our normal medication reduction, medication deprescribing. I don't like the OAB drugs at all. I think they have very high side effects and anticholinergic effects, and I haven't seen a big deal. I don't think they're particularly useful. But now is not the time to stop a medicine that might make someone go to the bathroom more, so they need to be changed more. Now is not the time to, I think, deprescribe that. So my point is that you want to look at each resident individually. Next, please. So I asked Nikki for the data. She said, show it to me. I said, okay. So I spoke to Dr. Marco, who's the medical director at Los Angeles Jewish Homes, and he said that he had over 800 orders, which is a lot. And I love the thing, many nurses have expressed their appreciation. And I think the nurses really will. And Dr. Fox at Lancashire Hall also mentioned similar things. Pharmacy jumped right to it. Notice the Optum sign there, Amy. So the Optum was very helpful for that. It's the MPs. They're getting providers on board. It helps with the med pass. I really don't think this is difficult to do. I've done a couple things. I go to multiple homes. One, I actually sat down with the director of nursing and went through all my residents in the dementia unit one by one and stopped medicines with her. On the other one, I talked to the director of nursing in both the nursing section and the the personal care section. And they're very on board with this, and they have really good relationships with the family, which helps. Next. Okay, so medication prescribing in the time of COVID, medication prescribing we're talking about here. So that's actually the opposite of deprescribing, I think. I think the point to be made here is this coronavirus, it's novel. Get it? Novel? Do you like that? Yeah, okay. I'm out of book jokes here. Next. I worked really hard at that. And what the hospital is doing is opposite of what we're doing. The hospital has these protocols where they have, 18 different medicine, and the consultants walk in and they start people on stuff. So it's different. Next. And everybody has lots of things. Hydroxychloroquine is the rage, and then azithromycin. I've had places that put ivermectin, vitamin C, zinc, steroids, non-steroidals, H2 blockers. You might have seen in the news the remdesivir was in the news yesterday. Teas. I will say I am not a fan at all. I think that giving them IV Clorox is a terrible idea, really bad. Nicole, I don't know if you should add that to the supplement. I think it's like a white paper or something. In my experience, it just is bad, not good. Okay. Next, please. It's just a thought. Now, I've been told that a presentation seems better than it actually is if you discuss your personal journey. So my personal journey is I was following the AMDA regs, the AMDA white paper, the guidance on this, which says don't treat. So what happened was I talking to a friend of mine in California who says their spouse had it, they started them on hydroxychloroquine, and the next day they were better. So I said, So then I was talking to a patient at the nursing home. She wanted her dad put on it, even though I told her, there's no evidence. She said, I want him on it. And the next day she felt he was better. So I said, Then I was talking to a friend of mine who's been at multiple personal care homes that have been just ravaged with this. It's been heartbreaking. And he said, I said, well, have you noticed any difference between homes where they put them on a protocol of treatment and those that didn't? And he said, well, the one that didn't had 15 deaths in 15 days, and the one 5 miles down the road had 2. So I said, So then I got a call from the pharmacist, the outpatient pharmacist who supplies medicines to personal care homes, calls me out of the blue and says, Dan, hydroxychloroquine, it's great. I got plenty of it. Extra supplies I ordered early. It's cheap, so it won't cost people anything. And it really works because there are studies out there that show that people who are on a Plaquenil anyway for other medical illnesses have a lower incidence of COVID. I never heard that. That's interesting. So I thought, well, maybe I will start putting people on it. So I did that. Well, then what happened is it didn't work at all. The personal care home where I put people on it, they just 15% death rate. The guy whose daughter thought he was better wound up going to the hospital a week later. So my decision has changed. And of course, that's all anecdotal. That's the trouble with treatment. Next. The data, and I have these slides for you, show, and these are not on nursing home patients. This is mostly with hospital, because that's why you use it in the hospital, so you can do some kind of, reasonable research on this. The study in the VA, not a great study, showed increased mortality with treatment. A French study showed no difference. There was a JAMA review of pharmacological treatment, and the upshot is no therapies have been shown effective. And that's the scoop. Well, we'll get to it next. Please. The ANZA statement basically says there's nothing besides anecdotal for treatment. It has side effects potentially, and it may lead to shortages, which is all reasons not to use it. Next. So here's the NIH, and this is, I guess the head, right? Basically says you don't want to use. There's nothing approved for prophylaxis if you don't have it. There's nothing recommended for post-exposure prophylaxis or treatment. There's nothing ordered for people who are positive for asymptomatic or mild disease, and there's nothing recommended for mild, moderate, severe, or critical illness. And to me, who am I? I think that covers it all. Next, in my opinion, in my humble opinion. Okay, now I don't want to be political here, and I listened to what Jackie said. I do not want to have slides that reveal anybody's PHI or a HIPAA violation here. So I have disguised, I think, pretty well who this person is. I just want to point out, okay, that patients hear things from people. And I understand when people are saying things like, and this was about hydroxychloroquine, it works great. France had a great test, and we don't have any time. We got to start stuff now. But the problem with that is, and I get this, leaders, people, us want to say good news to people. We just do, right? And people are desperate. Patients, families, doctors. We want to say something. Now, to go back for a second, I was doing a call with a bunch of patients at the families with the nursing home today, and somebody said, okay, when will remdesivir be available? I'm assuming it'll be available soon at the nursing home. They asked me this today. And I said, well, no. I respect Dr. Fauci. I do. But, he said this is a game changer. And I got to be honest, I'm not sure at all it's a game changer. I'm not sure. Do I hope it'll be a game changer? I do. But if you look at the data, remdesivir is a medicine that was tried for Ebola and didn't work. It's a preliminary study. We don't know, I don't think, if it was used on nursing home patients. It's used for hospital. It's IV. It's, I think, a 10-day. Is it, Nick, is that right? Is it 10 or 14-day treatment? It decreases the length of disease from 14 to 11 days. And there was not a statistically different outcome on mortality. It's a trend from 11 to 8%. But we don't know yet. We don't know the side effects. We don't know the cost. We don't know anything about this. But families want to grasp onto these things. And I think that's normal human behavior. But you have to take this stuff with a grain of salt. Next. So if you are going to treat, I would recommend against having a standing protocol for residents on it. And this is important. If you find colleagues who are doing this, try to dissuade them from doing that, because I really think the standard of care now, certainly for long-term care, I think actually everywhere, is not to treat. And I have something I think in the next couple of slides that will help you with that. Treatment is usually family driven. So when you talk to the family, and these conversations take a long time, you know, I think you say, here's what the studies show. This is my personal journey, because I think they'll enjoy that too. But there's no, you know, there's no evidence, and you really don't want to do harm. I don't like using the Tamiflu analogy. You know, flu. I don't like to use the flu to the COVID analogy because I think they're different. But the Tamiflu analogy is that if you're going to start something, if you are, you really want to try to use it as early as possible, 24 to 48 hours. Part of the problem with COVID is there's so many asymptomatics you don't know. If you're going to do something like this, you really need to document. Now, many people are saying, well, you know, we need to get an EKG. Is getting an EKG worthwhile, particularly nursing home patients, to have the person come into the room and get EKGs and serial EKGs? Well, it depends on what the family says. Like, if the family's going to say, look, I understand the risk of the medicine, but to me, I think the potential benefits of the drug, which may save my dad's life, is that outweighs the potential risk of QT intervals and cardiac arrhythmias. If the family says that, in other words, if getting the EKG is not going to change the family's mind and you've documented this, why should you get an EKG in the first place? Okay, now, anecdotally, next slide, please. There are lots of medicines that cause QT prolongation. I'll point out, you know, psych meds, antidepressants, antipsychotics, H2, you know, and PPI medications. You know, I'm not going to read through this whole list in the purpose of time, but I think it could be reasonable if you're going to start something like hydroxychloroquine, you might consider, with the help of your consultant pharmacist, stopping medication they're on if it's not essential that causes QT prolongation. Like many cardiac meds do that, I wouldn't stop those. But I'll tell you, I did have experience with a family where I stopped their antidepressant and their antipsychotic while putting them on that, and the family felt they were better off of the antipsychotic. So I thought that was interesting. So I think the upshot to all this, words to live by, next slide please, is don't just do something, stand there. Okay. You like that? Nod. Yes. Okay. Thank you, Amy. Next, please. So Nikki, this is your summary. Go to it.
Sure, Dan. I'm speechless. Like, there was so much content there in that short period of time. So
I'm sorry. Did I talk too fast?
No, you did great.
I'm sorry.
That's okay.
I lack self-confidence.
Oh my God, no, it's fantastic. So as Dan articulated, there's a lot of sometimes misunderstanding. So he tackled deprescribing and prescribing in a short period of time. So kudos to you, Dan. I just want to share a brief story because it passed through the borders of Maryland to Pennsylvania. But we got a question early on to your hydroxychloroquine, and actually put together a statement before it came out by AMDA just to guide the use. But you hit on the really key points, the risk benefit of any treatment approach, because so much is being pushed out in the general media. So our tool was not to focus on treatment. I just got to give that caveat. Our focus really was on medication management principles and optimization. So we stayed clear of the treatment because we know that there's a lot of volatility there and ambiguity, and that's why it's so important to work as a team to navigate the data. So again, the guide that I spoke to, I chatted upon within the box, is really to help you look at medication burden and to adapt it to your sites and your facilities. And again, communication is going to be critical, and Dan hit on that very well. And I thank you for sharing the data, because I think what we do know is there's existing literature, but very limited in the utility of any tool such as this guide or others. And there was actually a study that just came out, Dan, just 2 weeks ago, out of Australia, looking at simplifying med passes. And what they showed is that indeed, by using a structured approach, whether it's this guide or maybe another guide, but they had a structured approach. It shows sustainable changes by working as an interprofessional team. So just want to state, it really takes the team to make sustainable changes, not during changes during the pandemic. So next slide. I think that takes us to our case presentation.
I'll also point out too, because you're right, is that the hopes of this is that when this pandemic is over and we've identified people who have actually unrecognized effects of the medication, hopefully then they'll be able to say, you know, maybe this medication wasn't needed to begin with. So I am cautiously optimistic about that.
Awesome.
Well, thank you, Nicole and Dan. That was a very lively presentation. Let's open it up.
Lively.
It was lively, entertaining. No, it was very informative. Thank you. Let's open up to questions or any discussion before we move into the case, because I want to make sure we get anything, any questions addressed before we move on. So at this point, feel free to put questions or comments into the chat, or go ahead and unmute your microphone.
Yeah, because if you have had experiences with this, or you know you've had challenges that you don't know what to do, or even better, if you've had positive experiences and can share with us, you know, if there's something you feel is particularly important, or medication you've had difficulties stopping, really, Nikki knows all.
No.
Oh, I'm sorry. Maybe I meant Amy. I don't know. Come on, don't be shy. Somebody needs to ask something.
And I'll share some of the successes that you and I've worked on together.
That would be great. Okay.
All right. So there's 3 ways that we have gone about looking at deprescribing during the pandemic. And we were doing this before the pandemic, but it became even clearer once things started rolling through Pennsylvania and Delaware. The first thing was we looked at everybody with the goals of care of comfort on our patient list roster, right? And the nurse practitioners really focused on those patients and looked at their lists to kind of clean them up, so to speak, right? Did they still need every medicine that was on this list? And because if they were listed as comfort care, there was a family conversation that already occurred, and we knew we could build off that and have very good conversations around deprescribing. The second one was that we were already working on holistic approach. So Nikki talked about member-specific, having the team wrap their arms around the patient. And so we selected 5 members per building, 5 residents per building that were on over 11 medications, and had our clinical pharmacist do an expert consult. And then the nursing home leadership got together and discussed each member to talk through which medicines they thought they could deprescribe, and then would call the family. And then the third one was looking at some of the specific medications across the board and saying, do they need them or not? And the one we tackled most recently was sliding scale insulin, because there is a Choosing Wisely campaign about sliding scale usage in older adults and in the nursing home population. And this one was actually very easy to look through, pull the data on everybody who had it, and being able to show the providers and the families the Choosing Wisely data and recommendations was a great way for us to tackle that. So those are 3 examples of things that we've worked on in the past couple of weeks.
And, you know, Amy, I would say I agree, and thank you. I think part of it comes to the thing is that you need to have a champion, I think, for this, how it works best. Now, you, of course, you agree with this through and through, and you've been a champion. I think that in a lot of cases, hopefully, it'll be the nursing home's medical director should be the champion, but it doesn't have to be. I would think it could be the consultant pharmacist. It could be the director of nursing. I think somebody has to stand up, because I think, again, most people in the know recognize this, and it's such an opportunity, I think. You know, what we're not doing now, what I used a lot, I would like to go to falls meetings and say, when you have a falls meeting, you know, there's some things that we could do better. One is like, you know, look in the environment of how somebody felt, but looking at their medicines. I think a fall meeting in normal times was an extraordinarily good arena where you could look at the medicines and say, the medicines could be them falling. Let's look at that. The trouble now, which is so different during COVID, is that I found that falls is a frequent sign that somebody's COVID positive. you know, everything's so different now than it used to be.
Yeah.
And one other comment I'll make is, in case I forget, Nikki, is that when you look at the guide's online, it's great. I mean, it's full of so many great materials. But when you log in, you have to identify, like, do a very mild identifier. And then when you log in again, like I have over and over and over, it says, have you been here before? Yes, yes, yes. But they're open to input. So can you comment on that, Nikki? Because I think that's great.
Yeah, absolutely. Amy, great stories, and really want to hear the implementation aspects. So this is really helpful. So with respect to gathering, yeah, we are asking people who are downloading the recommendations just to give their name and their email and their affiliation. And we've to date had over 1,300 registered users, which is super exciting. We've had interest not just here in the US, but actually over in Spain, where they've been hit quite hard as well. And hopefully they're working on a parallel guide in Spanish. Again, this is free. We're hopeful that we can then develop future work and networks so we can, as Dan knows, you know, that academician, educator, researcher in me, to look at, you know, what are things that work and maybe don't work as well. So yeah, so we've been getting feedback, and we think with any sort of ongoing quality improvement, it's important that we gather stories. So to Dan's point, the story that he shared can be echoed by some of the stories that have been shared by others electronically. Had one story over the weekend where someone discontinued about 200 different medications in one building. I was like, wow, I hope they worked with the team on workflow, because we need to be mindful, right, of the impact. So hopefully that was, again, an alignment with workflow and others, finding out that it was many residents in that building, but still the impact on pharmacy. So there's lots of nuances to operationalizing any tool or guide. So this is why this conversation, as well as many that we hope to have in the future, will continue. So feel free, give us feedback. We sent out updated, one of the feedback we got from one of our partners is, can you give us references? So we put together a reference. So if you were one of the version 1 people, we put together last Friday an email we sent out to 1,100 users at that time, an updated reference list. Again, it's not exhaustive, but it gave some practical literature focusing on, again, nursing home and the evidence behind why we put those recommendations there. So yeah, so it's a work in progress, and again, really value, Dan, your feedback, Amy's and others that are on this call, as well as the important work that you're doing.
And I think those references are good. Like what I did, in one instance, I was talking to one of the physicians who said, well, I feel like we should use this and that. So I actually went back to the guide, copied and pasted what the comments were from the guide, and said, so it wasn't from me, so I wasn't the bad guy. I said, as per the guide, you know, DocuState is not considered effective, you know, quote unquote. So I think that's very useful. Now, I want to, if I could expand a minute, that Laura Finn was on the line. Thank you, Laura. And she asked a question about assisted living, as I gather, personal care. And the trouble with personal care, well, an issue in personal care is that probably most assisted living personal cares don't have medical directors. And that's an issue. And Jackie, you know, if we want to talk about a personal care assisted living in one of these later on, I'd be happy to. But a friend of mine said something that might be interesting if you have a pandemic or preparing for a pandemic is see if the home can identify an interim medical director to help with things like that. Now, again, many homes have a doctor who sees most of the, most of the patients. So it's like a de facto medical director who works with the staff. But I think if you can make some adjustments, assisted living personal care is a different animal. But I think there are ways that some tweaks you can make that can help people, even if it's temporarily. This is a disaster. This is a crisis. We're doing things we have never done in our lifetime. So I think moving outside the box a little bit is a good idea.
So I think, Dan, we get to the case. Do you want to present the case?
I'm going to let Amy. Amy does a very
Amy.
good job with presenting cases,
Awesome.
I think.
So this is an 81-year-old woman with a significant past medical history of advanced dementia, requiring assistance for all of her basic activities of daily living. And she's recently had weight loss, and her goals of care are comfort. She has a very devoted son who visits her regularly. However, he hasn't been able to due to the pandemic. And in the past, he did not want to make changes in his mom's medication regimen until she was truly end stage. He understood that she would eventually die from dementia. He understood that. Her BMI is 18, her blood pressure is 110/60, heart rate is 60. Her recent labs include a hemoglobin of 12, hemoglobin A1C of 6.2, and a total cholesterol of 130. COVID cases have been identified in some of the nearby counties, however, not in her building yet. And the son, who has been unable to visit, is somewhat anxious, and he wants to know what is best treatment given what's going on with his mom. Next slide, please. So here's the medication list. She's on twice a day metoprolol, omeprazole, donepezil, memantine twice a day, metformin, atorvastatin, iron twice a day, baby aspirin, glucosamine chondroitin, megestrol, multivitamin, magnesium, calcium carbonate, and DocuSafe. Is there an opportunity for better medication management? Dan, what do you think?
Can I answer? Can I answer?
Yeah.
Yes, I do. Was that right, Nikki? Was that right? Is that the right answer?
So if you
Let me unmute. Yeah, yeah, of course.
Wait, go back for a second. Go back for a second to the meds.
Yeah, go to the meds, please. Yeah.
So Nikki, why don't you start? You want to do one side and I'll do the other?
Well, I think I want to start with just principles before we get into the med list.
Fair.
Amy, I think you hit on a really important thing. The son hasn't been there in a month, and he's anxious, and he wants to know, what can we do that's best for mom?
Yep.
And I think right there before you tackle the meds is really to let him know that you're caring for. I think this is setting the stage for conversations, right, which are much more than just the medication list. So I think it's important to understand. I've been doing work with ECHO and the 4Ms in Age Friendly, so I have to give that disclosure now. But one of the things I talked about a couple of days ago was when we talk with families and we start talking about what matters to them when they're caring for their loved one. You know, a lot of it is keeping them safe and making sure that their needs are being met, just one example. But when we weave in that conversation with medications, you know, as we talked about, one of the principles behind the guide was reducing transmission of the virus, you know, preserving our workforce. So I think it's setting the stage for that conversation. So I think meds are just one angle of it, is kind of the principle I'm getting at, but more importantly is giving him some relief for his anxiety, because he probably thinks, oh my God, if you were just to start to say, hey, I want to stop about like 90% of your mom's meds, that he might get a little bit more anxious. But if we put it in the context of the why and what matters to him, I think that makes even a more meaningful conversation. So
yeah,
I just
I
start with
agree.
that. Yeah.
Yeah, and you know, Amy and I have had this. Amy presented this case initially, so I didn't think we should stop 90%. I thought 100, right, Amy? That's what I had picked. But I think also, you know, part of this thing is, you know, the son's definitely involved and anxious, and we can't get over the fact there is tremendous family angst about this, just tremendous. You know, so I don't get angry at them even when they trash me on Facebook, because they're, you know, it's this whole thing that's happened. It's so upsetting. It's such a bad thing. Yeah. But I think if you're going to wind up having discussions with families about why don't you want to go to the hospital, you know, should you go to the hospital or not? You know, there's many reasons. You know, going to the hospital is more confusing for older people. They're not amongst people they know. You know, there's a chance of getting nosocomial infections. Are they really doing more for them in the hospital or in the nursing home? But something else you could add to this conversation is that there's a good chance they'll be started on medicines they don't need in the hospital. So just as a general overview. Amy, do you want to comment? What do you think about this case?
Well, I see the hemoglobin A1C of 6.8, and she's losing weight. You know, there's So first of all, the hemoglobin A1C less than 6 point, at 6.8, the goal for somebody in her age range with her advancing dementia, I don't need to keep that tight of a control on her diabetes. I'm more concerned about a hypoglycemic event. So I would definitely get rid of the metformin. Megestrol is not a medication that's often prescribed for anorexia and dementia and puts them at risk of other things like DVTs. So I would get rid of that. Her blood pressure is a little bit on the lower side, so I would think about the metoprolol. Maybe she doesn't need as high of a dose, and we could decrease that. The donepezil and memantine, I would have a risk-benefit discussion. They have side effects like anorexia that could be contributing to her weight loss as well. So I would be looking at those differently. And then the aspirin and atorvastatin, if they're primary prevention, I would be having a conversation with him about her life expectancy and whether or not they're helpful. And then the rest are supplements and the PPI. So I would want to know, does she have a history of a GI bleed, gastritis? Is there a reason to keep that on board or not? A lot of times those medications get put on during a hospital stay and they end up on forever. That's just and then there's Docusate on there, Dan.
So you would keep that? No,
are you kidding me?
I just think I think we're lucky. I think we're very lucky that you had this patient who has all this. Because this turns out to be a very good case study, I think. So kudos to you.
And then, if the glucosamine chondroitin has been on for a while for osteoarthritis, and I would have a conversation about whether or not it's been helpful or not. And so I think there's a lot of stuff you could get rid of.
Yeah, I didn't think there was evidence in humans that glucosamine chondroitin. I don't know what if you know anything, Nikki, but what I've seen is that it could work like in dogs or horses, but there's no evidence that it works in humans. Have you seen that at all, Nikki?
Well, there's been some studies, Dan, outside of the animals. There have been human studies, but you're right in terms of the mixed evidence. It really depends on the severity of the osteoarthritis and how long they're on it and what doses. I want to give a slight caveat to Amy's perspective. I know we didn't provide doses here, but I think to be mindful of PPIs because depending on what dose and how long, we can actually sometimes make our patients, residents more symptomatic if we abruptly discontinue them too quickly. So I think, just being mindful of some of those approaches are really important, but Amy articulated well the risk-benefit conversation for each and every one of those. So yeah, so there is some data, Dan. It's not fantastic, but in my mind of glucosamine and chondroitin, it's a much safer option than some of the other things we have out there.
Oh, no, no question.
Right.
Yeah, but again, I personally would prefer acetaminophen over the glucosamine chondroitin.
Yeah.
Yes.
Me too.
In terms of the data. Correct.
Well, Amy, thank you for that case. I wanted to see if anyone who's online has any questions or comments about the case or the lecture before we wrap up. I appreciate everyone staying a few minutes extra. Again, Amy, thank you so much for that case. Thank you, Dan and Nicole. A couple of quick wrap-up announcements. A reminder that you're able to collect CMEs for today's session. Survey is sent out with a link, and you can use that link to get your CMEs for any of the sessions that you attend. All materials will be shared via email. And finally, we hope you'll join us for our next ECHO session scheduled this Monday, May 4th at 4 p.m. And Dr. William Callow will be discussing efforts to reach our minority patients during COVID-19. Thank you all for joining us, and we hope to see you again.